Hello, everybody, and welcome to today's webinar entitled Advancing Patient-Centered Measurement in Team-Based Care, and will be presented by Selena Davis and Marcy Antonio. And the name isn't on here, but we have a moderator today, and our moderator is Paul Bergener. So our Methods Matters webinar are a monthly webinar series put on by the BC Support Unit's Methods Clusters, and it showcases emerging research and patient-oriented research methods. We do actually have a hashtag today, and it's on the screen, and today's hashtag is Method Matters. So if you'd like to tweet about it or share information about today's webinar, please use that hashtag to do so. I would actually like to acknowledge the ancestral traditional and unceded territories of the Squamish, Tsleil-Waututh, and Musqueam nations from whose traditional lands the BC Support Unit operates in. We actually encourage an attitude of continuous learning here, so we approach new ideas with diverse perspectives and with openness, respect, and curiosity, and we aim to center previously underprivileged voices. So with that in mind, I'm going to stop sharing my screen, and I'm going to pass the mic over to Paul to introduce our presenters today.
Hi, I'm Paul Bergener. I'm a patient partner as part of the research team and your moderator for today. Today, the two presenters, initially we have Dr. Selena Davis, a research scientist and digital health consultant. She's passionate about empowering citizens in health and care via integrated digital health ecosystems and intelligent clinical tools and information technologies to improve patient care and outcomes. As the second part of the presentation, we have Marcy Antonio. Marcy is a PhD student at the University of Victoria, whose research focuses on digital health equity. So we will turn it over to Selena, who will begin our presentation.
Thank you, Paul. I will stay in the realm of gratitude, and I'd like to thank you for joining us today. And I want to first extend our thanks to all the patients and providers who shared their insights over the course of our study, and certainly to our collaborators at the Kootenay Boundary Division of Family Practice and our industry partner, Cambium Business Services. The study was conducted during the pandemic when all of us were being impacted, and still are, by changing healthcare resources. And so also gratitude to our patient partners and co-investigators that you see on the screen here. So to begin, we are often asked to complete surveys, for example, or questionnaires about our health and our care preferences. And these are what we call our patient-centered measures. And so it asked our group of researching teams and patient partners, et cetera, to ask ourselves, how can we meaningfully integrate these data into care and make care patient-centered, support that direction? So we understand that there are two kinds of patient-generated data: experience measures and outcome measures. We also, in terms of a background perspective, thought about where BC was transitioning to in terms of its patient-centered model of care, and that is it's team-based and it's described as the patient medical home. As BC shifts to that model, there's a need for a new patient-centered measurement methods that can account for the nuances in this emergent model of team-based care. This does come with challenges. For example, there are multiple challenges in the ways to collect, track, triage, or trend patient-generated data, and most clinics operate under a resource-constrained environment. So to address this knowledge gap, we conducted an exploratory study with the aim to conceptualize new ways of incorporating patient-centered measurement into team-based care as part of the patient medical home model here in BC. In this presentation, we'll summarize the study results and more specifically share the new methods resulting from our study to encourage the sharing between patients and their care team of patient-generated data and how this can make patients' care more patient-centric. We conducted a study comprising multiple methods and stages within a rural community team-based clinic and with patients with mental health concerns. We explored care team mapping, a portal, care pathways, workflows, and our evaluation comprised interviews and an analysis of all the data we collected to conceptualize these new patient-centered measurement methods. Our patient-oriented research included 2 patient partners on the research team who were involved in all aspects of the study. Our approach was one of knowledge sharing, including iterative learnings from the patients, providers, and clinic staff who participated in the study. Along with our commercial vendor, patient partners, and the patients and clinic team in the study, we advanced the development and implementation of a portal. A couple key features of this portal are displayed on the screen. While it looks a bit busy there, the one on the left really just indicates the questionnaires, for example, or surveys, measures that the patient could complete. And then on the right is an example of a trending graph showing patient data from one of the questionnaires completed over time. To summarize the uses and care workflow of patient-generated data using the portal, which resulted from the study, I'd like to share the video that was created.
Integrating patient-generated data into clinical care. Let's talk about patient-generated data. What is it? How do we gather it? And how can we use it? You might have already gathered some patient-generated data about yourself. Like if you've done a paper-based survey while waiting for a doctor's appointment that asked you about your quality of life or the care you receive. Or you might have generated some data by tracking your symptoms, blood pressure, or mood. Patient-generated data like this can be used by patients and healthcare providers to improve care and make it more centered around the patient's values and preferences. Currently, we don't collect or use patient-generated data as much as we could, or should. In our research study, funded by the BC Support Unit's Patient-Centered Measurement Methods Cluster, we worked with patients, healthcare providers, and collaborators to investigate what are some of the ways that patient-generated data could be better integrated to support care decisions. One way we could use patient-generated data more effectively is with patient portals, which are electronic tools that allow patients and healthcare providers to securely access and share health information, and allow for secure communication. Some patients are already using patient portals to book appointments, view test results, and view their vaccination histories. But we are still figuring out how we can best collect and use patient-generated data within them. Here's a few ways we found in our study. One key use of patient-generated data is to support patients and providers in their decisions. A patient and their provider might monitor a treatment decision between appointments. Or a patient might observe their own data in the portal and then make choices for themselves based on what they see, say celebrate their progress and continue with their current treatment, or choose to book follow-up appointments and seek different treatment. Patient-generated data can also help a patient identify who they might connect with on their care team. For example, if they notice a significant change to their mental health score, they may decide to set up an appointment with their social worker. A portal could help track patient-generated data over time, like if it was programmed to send regular reminders to the patient to complete surveys or screening tools. As the patient continues to collect this data, this would allow them and their providers to more easily see changes in their health over time. For example, they might observe how their depression impacts their life more in winter, or observe their progress in recovering from an injury. The patient-generated data in the portals could also be used to support clinic visits and a patient's healthcare team. If a patient is regularly sharing their data with their healthcare team, the portal could alert their team when further care may be needed. For example, data that indicates higher home blood pressure, blood sugar, or depression scores could automatically indicate the need for a patient to come in for a clinic visit. Just before a visit, A patient's healthcare team could send a reminder to the patient to collect some new data, for example, by using a survey or a screening tool. This newly generated data and a patient's previously generated data could then be shared with their healthcare provider to support discussions during the clinic visit. And when the survey is a key part of the visit, this can also help a patient better explain their priorities. For example, a patient could highlight certain questions and responses in the survey that they care about most. Finally, a portal could help empower patients with education and knowledge. They could provide patients access to information and resources that are relevant to them, such as evidence-based articles from trusted sources or links to local community resources. As technology improves, these resources could even be tailored to a patient's needs and preferences. These are just some of the possibilities for how we could use patient-generated data to support care, from tracking your health and planning care visits, to making decisions and accessing educational resources. Patient portals are not widely available yet, but portals are beginning to be integrated and will continue to be. And we need to make decisions about how patients and their healthcare teams can use data generated in the portals. So what do you think? What are some uses you see for a patient portal or patient-generated data? Would you want to be involved in studies that are exploring these possibilities? For more information, visit pcmintbc.uvic.ca or contact Selena Davis at davis@uvic.ca. The funding for this project was provided by the Patient-Centered Measurement Methods Cluster of the BC Support Unit. Learn more at bcsupportunit.ca/methodsclusters.
Thank you. So some of the key learnings shared through the video that we just saw, and thank you for the support from the BC Support Unit in creating that video with us to illustrate some of those results of our study. Some of the key learnings were the value of electronic delivery of measures and questionnaires and the related alerts and notifications and trending of data that are possible, and the use of tailored resources, and also the use of data to support care decisions and clinic visits. In terms of just overall study results, for patients with mental health, we learned that stigma is still a concern, and equitable access to technology, in particular in rural communities, is problematic. We learned that there's limited knowledge about team-based care. With the use of digital patient and provider tools comes challenges around communications and expectations. From a clinical team workflow perspective, we identified the inadequate electronic support for tracking and integrating patient-generated data. And there's also an insufficient resources to gauge and sort of quality improvement approach around that. We also conceptualized 5 methods to advance patient-centered measurement in team-based care. 2 of these are the focus of the remainder of the presentation. The first PCM method, or a patient-centered measurement method, the digital tool exploration, considers different tools, stages, types, ranges, and levels of technology in assessing a patient's and provider's readiness towards adoption of digital tools and the impact of these tools on the adoption of patient-centered measurement. The tools and technologies used in our study included a clinic EMR, or electronic medical record, portal, the external analytics programs that support things like quality improvement activities, web-based online systems for resources, some virtual meeting tools, and communications tools like text and emails accessed through laptops, desktop computers, and mobile phones. The digital tool exploration method could be used to assess the impact and readiness for digital tools introduced through patient-centered measurement. This method has the potential to enhance understanding regarding the level of patient, care team, and technology readiness, and helps to determine when, where, and how patient-centered measurement can be implemented to improve patient and provider interactions and care team performance. In terms of readiness, it involves evaluating current digital tools being used for team-based care, the maturity and the interoperability with and between the existing systems, the usefulness of tools to support patient-centered measurement activities, and available resources for patient and providers. In our study, options to incorporate patient-centered measurement were viewed as problematic as digital tools and technology were not connected. The lack of interoperability between systems was frequently mentioned by patients and providers during the evaluation. One example of resulting problem was the lack of alerts for changes in questionnaire scores that should trigger actions. Although one care provider simulated a linkage between the portal and the EMR, they commented that the effort was not scalable or sustainable after the study ended. Going forward, this particular patient-centered measurement method would highlight the need for this aspect of readiness to be addressed. Looking at other aspects of readiness, the sudden transition to remote visits during the pandemic meant that both providers and patients could potentially view the completed measures together through their computer screens. However, interestingly, none of the patients considered logging into the portal prior to a clinic visit. One patient mentioned how previously they were less likely to accurately report a patient-centered measure score during an in-person visit, as they had to. These patient-centered measures were deployed in public spaces like a waiting room, whereas a virtual waiting room with this virtual visit experience offered a new possibility for patients to complete measures in less public ways. In terms of usefulness, patients reported that the portal was easy to use and added value to their care in several ways. One patient noted that the use of portal was a way to overcome isolation. Another patient reported that it was helpful to have credible information and not rely on sort of the Google and getting lost in the abyss of overwhelm with resources. Finally, while providers appreciated the potential for tailored educational resources, they recognized that they would not have the time or domain expertise needed to sustain this in the portal. We move over to the impact aspect of this method. It considers how the introduction of new digital tools may unintentionally shift patient-centered measurement processes for team-based care, and the success of these digital tools in supporting patient-centered measurement for such care. In terms of our findings in our study, an example of the impact was seen when a patient described speaking with a resident doctor during a virtual visit. As this resident doctor was not a study participant or had access to the portal in the study because of that, nor did they know where to find a questionnaire score like the PHQ-9 questionnaire within their EMR, the resident suggested to the patient that they both Google the measure, which enabled them to talk through each question before deciding on a medication change. One patient who was often afraid to talk with a physician about anxiety noted that completing the questionnaire and trending the data before the visit ensured that all pertinent aspects were covered during a visit, preventing some communication disconnect. Another patient expected that patient-centered measures would be discussed during care visits and certainly readily shared with other care providers, for example, like referred specialists. This patient actually stopped completing the measures near the end of the study. And during the interview with that patient, they explained that one of the reasons for this was the disappointment in not having the measures discussed during the care visit. For physicians, the portal was seen as extra work and not accessed by them, but rather the task was assigned to the registered nurse in terms of within their team. In general, providers saw the portal as having benefit for patients, providing information and offering them a sense that care was nearby. So to wrap up this method, I wanted to provide some examples from our study that you may be able to apply or consider when looking at this method and implementing patient-centered measures. For patients, the consideration may be in the way the digital tool be used in actions that may take to increase usefulness or success. For providers, it may be to identify usefulness of current digital tools and technologies and opportunities to improve processes with their use. I'll turn it over now to Marcy to carry on with the second method.
So yeah, I wanted to begin by acknowledging the lands of the Songhees, Esquimalt, and Wasanich peoples from where I'm calling in from today. And it's with great gratitude that over the past 7 years, as a visitor on this land, I've been able to work with different patient populations focused on improving our care systems. As the video highlighted, patients are generating data through these different measures, but these measures aren't yet living up to their potential for bringing in patients' values and perspectives into care visits. I wanted just to emphasize that the methods that we are talking about are different to a research method, but are seeking to provide some guide on how the data patients generate can bring together a care team to improve care. And today I'm going to be presenting on the second method, which is shared learning. So shared learning is a method that emerged from what patients talked about in completing the measures. The quotes presented today are directly from the patient participants. And the first quote that I wanted to highlight, it really reflects how validity was a common term patients used when we asked them about how they were finding these measures within the portal. One patient said that they find it unexpectedly rewarding and validating and quintessential learning for the doctors in understanding where I'm coming from. This reference to validation was what first led us to conceptualize the shared learning method. So shared learning involves having the team use measures in ways that introduce opportunities for patients to have the perceptions of their health and illness recognized and valued. It involves linking patient-generated data to resources that are of value to patients. Within the shared learning method, we identified 4 concepts I'll go through today, and I'll first give an overview of the concept and then provide an example of each. So identify is the first concept in the method, and it involves prioritizing the issue for the patient based on their values and preferences, and then developing strategies that align with the patient goals and context. The action plan was one form of a measure that we incorporated into the portal, in addition to what Dr. Davis had mentioned around patient-reported outcome measures and experience measures. And the action plan really demonstrated how patients can bring up a concern and then set goals for this concern. When we asked one patient about completing the action plan in the portal, they said, "It allowed me to see where I'm at, and in acknowledging the depression when you put it down in the action plan." With shared learning, though, it would involve moving these actions forward with the team. And this could be working with the team in developing some strategies on how to address a patient's concern or how to help to modify their goals so that they are attainable. An example as how we saw Identify being discussed was when a patient had completed the PHQ-9, which is a measure that focuses on depression. As the video showed, one of the questions in the measure is, how often have you been bothered by overeating or loss of appetite? The question allowed the patient to link their sudden weight loss to the depression. And before this, they had not realized the possible connection. In becoming aware of this, it made them think of possible changes of how they could link it to their current mental health. The next step within the example that we didn't hear, but introduces a possibility of, is how this new insight could be brought forward to other members of the care team, perhaps connected to the social worker for counseling or a dietitian who could work with the patient to discuss the loss in appetite and weight loss. Connect is the second concept in the shared learning method, and it's about providing a shared language for all members of the team. Patients mentioned how they could use the measures as an outline for care visits, where both patients and providers are viewing the measures to give common terms to support communication. The measures gave patients a way to communicate their severity of illness during times when they may find it very difficult to talk. It gave them a way to focus the visit on their current health concern. Having the measures in the portal potentially allows for ongoing care that does not have to be linked to a clinic visit. When patients completed measures outside of a clinic visit, the team could be alerted when they may need to reconnect, rather than wait for the patient to schedule a visit when their illness may have progressed to quite severe. This concept of Connect was demonstrated when one patient said how the measures allowed them to use the language of providers and to be on the same page. So an example of Connect was demonstrated during a virtual clinic visit with a resident doctor. And this is the example that Dr. Davis had mentioned as well, where the patient had mentioned how they were part of the study and had recently completed the PHQ-9. The resident didn't have access to the portal, so recommended that they Googled the PHQ-9 and they could walk through it together while they were both on the phone. The walkthrough allowed the two of them to quickly connect and focus on the current concerns of the patients. The patient found that the visit was more productive and satisfying than having to spend the first couple of minutes getting the doctor caught up on their health, which often they found involved revisiting past notes before they got to the current issue at hand. The patient felt it changed the decision on medication choice because they were using the language that could connect to what doctors would want to know in making recommendations on treatments. Understand is the current third concept within this method. It considers the influences of different contextual factors that may impact a patient's health condition. As the video highlighted, having the measures collected throughout the year can also allow for recognition of changes to mental health during different seasons. And that also points back to the graph that Dr. Davis had that shows the different trends over a series of a couple of years. Understand also involves using patient-generated data to decipher different aspects of a patient's health condition and context. This was demonstrated through offering a selection of measures related on mental health. For example, we had measures on anxiety, depression, and self-efficacy. This concept was further demonstrated when one patient said how the measures allow them to probe different things that I'm not aware of that impact me. This leads us into the example for Understand, where one patient referenced the problem of self-efficacy when they spoke about the importance of focusing on self-confidence. They said, self-confidence is huge, as I find this to be a very difficult aspect of the disease. This same patient also spoke about how completing both the PHQ-9 and GAD-7 had really helped them to realize the distinction between their depression and anxiety. At the end of the study, they had found that the scores on the PHQ-9 had decreased, but their GAD-7 scores continued to be high. And this made them want to better understand their anxiety. Evaluate is the final concept within the shared learning method, and it involves following the team trends over extended periods of time. We found that currently patient-generated data is commonly only being used at a single point of time, and most often during a clinic visit. What we discovered is that patients want the ability to follow their trends and not just have the provider review a single score during visits. Having both the patient and provider review the trends can provide a way to identify significant changes outside of regular visits. It can be used to see changes from between visits, to evaluate the impact of a treatment, and it can also be used outside of regular visits over the long term to evaluate other causes for these changes. And sorry, just noticed the trend. So one of the quotes the participants had shared was the measure itself did not provide insights to what created my responses, but they still found these measures very valuable in their day-to-day care. We found repeated examples where patients wanted to have the ability to follow the trends on their data. This was demonstrated during the final interview with one of the patient participants. And they talked about how they had just recently gone back to the data they had generated in the portal earlier during the study. At the time, they had not seen any change in scores, but when they looked back, they found that their scores were higher than they remembered. They reflected back on what had been going on earlier in the year and how this had had a bigger impact on their mental health, and how they were now looking to keep a closer eye on changes to their scores. To summarize, the method of shared learning involves the 4 concepts of identify, connect, understand, and evaluate. The last thing that I wanted to highlight was in this method are the concepts of shared and learning. The shared component highlights how this involves learning opportunities for all members of the team and the importance of relationship building with the team. The learning component is highlighted by the circled arrows and using the measures in a way that supports communication. One patient highlighted the importance of this communication that was specific for mental health. When they said it again, said that it was very difficult to experience a severe bout of depression, and the measures gave this patient a way to communicate the severity. The 4 interconnected concepts with the method of shared learning with the team was further demonstrated through team interaction during the study. Over a period of 4 months, one provider was given the role of monitoring the measures within the portal. During their weekly review, they evaluated a significant change to a patient's score, and they called the patient to discuss the measure, and together they identified the priority issue. The provider then suggested to the patient to connect for a follow-up appointment with a social worker. Understand would involve the social worker working with the patient to understand contextual factors that may have been impacting their health. So just to wrap up, how can this method be applied? We want to provide some examples for you from the study that you may be able to apply on your own. From a team perspective, it could involve the team separating out the questions for different members to focus on. For patients, these measures could be taken into a care visit to use as an outline. Many of these measures are available online, so both patients and providers can access them. Providers can provide multiple measures that could help the team members decipher different aspects of a patient health condition. And it also involves thinking how to use the patient-generated data beyond a single visit and in monitoring trends. As the video highlighted, the last example is more challenging, and we might not be there yet, but there are ways that we can think about moving this forward in small incremental changes. So some next steps. Today, we only had the chance to review 2 of our methods. So Dr. Davis talked about the digital tool exploration and shared learning. There's 3 others that we've had developed, which are team mapping, longitudinal care alignment, and quality of care improvement. And we are in the midst of updating our website so that it can be used as an online guidance document on how to apply these methods. We're also in the midst of completing 2 publications that we're aiming to submit this month. And I saw a question in the chat window about the video that will be available online. And we're also considering other possibilities of videos as well. So thanks to everyone for attending today. And I also want to thank our patient partners, Paul and Mindy, who are joining us today, and to all the patient participants and providers who provide their insights, as well as our industry and collaborators, our industry partners and collaborators. And here's just some information if you want to connect with us. We have our email and our website there as well. And then I have a question overall for the participants today who are attending today. Does this method resonate? Was the method clear? And similarly with the digital tool exploration method, that are there areas that we could really help in your clinic or as a patient? So thanks everyone, and I will turn it back over to Paul.
Thank you very much. Yeah, so I think we learned a lot there, and as Marcy said, there's a lot more coming in that'll be available on their website. We do have some questions that have come in. One of them is the portal available in English only? Do you recall, Marcy? I believe they had it available in French, and we're starting to look at other languages as part of the company's efforts to move forward. Is that correct?
I actually don't know. I can find out and I follow up on that. So I'll definitely check into it. My focus actually for my research is around health equity. So the language question is a huge one for me. It's something that it's one of the first things I go to, and the importance of offering these technologies in multiple languages. So thanks for the question. Very important to consider.
I'm pretty sure, Polly, that your answer is correct. I think your industry partner has indicated that to us, but worth following up for sure, Marcy.
Yeah, certainly technically there was no problem with using other languages. It was more a question, it was directed, they put together a special package for a research project, so.
I just had a further thought on that too. I think what the portal highlights is that we were creating customized resources, and so we could integrate other languages, and the measures are available in other languages. So the PHQ-9, the GAD-7, I can't remember how many, but those are available in multiple languages, and the resources we select could also be available in languages. So there is that way to do that. But I think it would also involve working with patient partners who are part of that culture as well, and making sure that we're choosing resources that connect with the patient populations.
Right. Okay.
Paul, one thing before you pose another question that I wanted to remind, I believe, Amber, you can perhaps post a chat if it's true, but my understanding is the video is posted on BC Support Unit's YouTube channel. So that might be another way that it could be accessed. And if that's so, maybe you could share that with our attendees today.
Yeah, you might also put the very quick website in the chat so people can copy it, perhaps might help them find where your actual website is. So we had a question said, regarding utility and data display, is the application of statistical process control methods to distinguish and potentially automate detection of important changes or trends in temporal data, rather than just subjectively reacting to any or all of the random variations in graph data. Elsewhere, past examples include monitoring quality of diabetes control, determining when to change modality of the physical therapy treatments, etc. Could you answer that one, Selena, as I know you had also done in your previous work with diabetes and had to deal with some of the more quantitative tools that are available from these types of patient measurements.
Yeah, thanks, Paul. That's an excellent question. Thank you for presenting that. It really highlights the direction we are heading when it comes to analytics, clinical decision support, and even fancier terms like machine learning or artificial intelligence. But at a very from a very clinical perspective, extremely valuable to provider, as we always hear about the overburden of data and information and workload within a clinic structure and team-based care, et cetera. And so the ability of these types of tools, analytical tools, to offer both the patient in a way that they need to receive it, and the provider presentation of the data, and to trigger alerts and notifications when those are within an evidence-based range of concern, are absolutely valuable, and absolutely the direction in which decision support and artificial intelligence tools are heading. So I think while we are still at the it seems like the early stages of even trying to integrate systems and even just get them up and active, this type of research and innovative research and design development in industry is occurring and will be part of our future.
Oh, thank you. And here's one for Marcy, I think. The question is, what strategies will you use to convince patients to enter their personal data into the application? Do you think some people might be afraid to share all of this data? I think, Marcy, you did quite a bit of review of the patient responses in some of the interviews. And what did you find about patients' reluctance to put in personal data?
Yeah, so Selena and I co-facilitated the interviews, actually. So so yeah, we brought in different insights. So I'll turn back over to you, Selena, after I'm done. But yeah, I think one of the things that highlighted for me was the importance of relationship building with a technology. It's not just having patients enter in data into a technology, but the importance of having a team to reassure people that the tools are going to support their care, and working with our industry partner to also provide some insights around how we make sure that these are secured data sources so that we can convey that to patients as well. I think really key components. And yeah, to know that their information is being viewed really helped to keep patients continuing to use the portal. If they found that, I think the example that you provided, William, was great because it demonstrated that if it's not being viewed, people are less likely to continue to use the portal. So, yeah. So I'll turn it. I don't know if you have anything to add. Yeah.
Yeah, I think it's always, while our sample size was small, and you're never certain whether you have folks interested in participating and who are interested in technologies, etc., and use them often in their lives. But generally, the idea of being fearful of putting information in so that it is seen and shared from a patient perspective is less frightening than we often think. In fact, they expect it to be shared for optimal care. And so we often hear that there's a trust and that relationship piece that Marcy brought up, but there's also this desire for, I'm putting all this information in so that my care is actually optimized amongst a team and shared, for example, with referring providers that are required to take care of me. So I guess that's all I just wanted to add is I'm always, while the literature might often bring up these ideas of some fear, and rightly so, we often hear contrary to that in such interviews.
So another question is, how accessible is the portal with programs such as voice recognition and screen readers? That one I can probably answer. They were still going through, something that followed more the typical clinical use of the patient measurements. So although these were things they certainly talked about being available, it wasn't available during our study time. And again, we had a fairly small sample group. So the people were pre-screens that they would be able to interact in a typing and reading situation. A second part of that question was, how is security, privacy, and data ownership addressed? I often have to complete patient intake forms that include similar questionnaires online. Rarely do I find the security and privacy information provided in sufficient detail to make me feel safe or in answering honestly. Not sure, Amber or Selena, which one might want to answer that.
I'm happy to start it off. I think that thank you for raising that question, again, in alignment with the previous question at many levels. Absolutely valid. There are so many entry points for each of us when we're our patients into portals, and whether that's our providers community or primary care tools that they're using, like their electronic medical record, or completing web-based aspects of surveys or measures. And we don't understand how they are all integrated, and likely more not integrated with the rest of the systems in our province or otherwise. And so there are, absolutely, as we sit in this muddle puddle at this time in our digital health life, it's reasonable to question that. And I think when we are working direct with relationships and our providers, asking that question of them and the systems that are being used and how well they're integrated is a very worthwhile question before putting that information out there. And perhaps asking again yourself the question about the difference between the how well I will be cared for by providing that information if I'm honest with it, versus the fact that it might be taken from a confidentiality or privacy position. So there is a fine balance today as we not fully understand the back end of technical solutions. And so asking those questions out front are worthwhile, I think, at this point.
I'm just going to add a couple of things within the portal. So when patients were asked to sign up, there were really clear terms that patients could review. And then in the portal, they're listed there as well. So patients can always go back. And we did work really closely with our industry partner and with the UVic privacy officer to make sure that we really it adhered to the privacy guidelines. So it was a very secure environment. And I think that gave patients reassurance too in knowing that. And I think there was another part of how patients share their data. So this was a unique aspect of the portal is patients choose who they want to share it with. And so eventually down the road, in thinking about interoperability, patients can choose if they want to connect their data to different health systems. So the new one that's coming out from the Ministry of Health Gateway, this would be our ideal, I think, where patients can go, yes, I want this data to go to this system and this data to go this system. So they are true ownerships of their data. So that I think is where we really would like to go. And yeah, so thanks.
Okay. There's several questions that I think I can sort of pull them together here. Based on the prems and proms, there's a couple of questions asking, had the people previously used those? How did the clinic make use of it? And how was it being evaluated, I guess? So that's kind of three questions summarized together. But yeah, they're looking for some details on the prems and proms and people's background and the clinic's understanding and use of them in this study.
You want to go? Should I go for it? Okay.
Sure. You go ahead.
Yeah, I'll start and then you can add. So yeah, there was a range of experience with prems and proms. So one patient talked about, I've seen this before and was very familiar with it. And so that was that quote that I kind of stumbled on, and then I realized it was really, they had seen these measures before, but having them consistently go out every 2 weeks gave them a way to constantly check in, which they really appreciated. And I think, and the clinic also had used the measures, but what was different was how to integrate it into the technology. And so I think when I'm talking about the need to view these measures, it was a really new thing for the clinic to experience the portal. And so that interoperability piece is huge, I think, and also just changing a clinic's workflow and how they actually access it became really apparent in working with these teams and understanding how you can integrate it better into the clinic when you're shifting processes like we were trying to do during the study.
And maybe just to add a little bit, I think one of the parts of that question was in terms of when a prem or prom, an experience or outcome measure was or experience measure was asked, whether it was before, after, or during sort of a visit, and the impact of that. And absolutely, that is worth another research study, and I could imagine that would be the case. There would be some changes to those pieces, but we'd be curious to explore that further. And that also would require the research study to have a larger sample size, because I know we did hear that, and we're concerned that if we had a small numbers and we asked the experience measure, that would inadvertently identify which patient was expressing concern because of the small sample size in our particular study. So I think that is certainly a next step in looking at the timeliness of those measures being collected and valued for the clinics.
Yeah, questions from all over the place. Certainly there was some response back to the question about security on it, that it is a secure system there. You know, the person has control of it, not the clinic of the portal. So there was a question also about family input into it, that family often knows more things that are able to help understand a condition. Again, based upon the ownership of the portal by the actual person, they can invite other people to also participate in that. And so that the family is again discretionary with the person that is signed into the portal, not with the clinic. And so they have control who does that. Let's see a few more things. There was certainly a question here about in the chat side of it, that it appears that the client has to catch up on medical jargon in order to be on the same page with professionals. I didn't hear that it's reflective of the client's language. The model didn't seem to be person-centered. Could you respond to that one, Selena, please?
I absolutely could, and I wonder if Marcy really wants. This is this idea of equity in language is really part of her seat of her soul, I think. But absolutely, our intention was to ensure that our patients' voices were a part of our design, implementation, evaluation, all the iterative aspects of how Portal changed as a result, what the evaluation questions looked like, the choice of our prems or our proms, the ways in which questionnaires or resources were tailored within the system, etc., and worked closely with our vendor, commercial vendor, to do so. So it was a deep intention of ours to do so, of the research to be patient-centered and to consider patient and family, perhaps a little less of family, because we did not include family directly within this research study, but patient centered around our language and even our publications, our intentions today. So I think if we've missed the boat, it'd be really valuable to learn in ways that we could get on the right boat.
Yeah, I'm glad you brought that question up, Paul, because that is the one I'm interested in, because I want this to connect with patients. That is always my goal. The shared learning one in particular did come from patients' language, but it may be the way that I'm communicating it. So if there's things that I would love to hear, so please email me. If there's things that didn't resonate with you, please let me know. The other thing that we are looking at is for our website, how do we communicate these methods from a patient perspective, from a provider perspective, because the team has different aspects that they would use within these methods. And then the other ones, there are some that I think are a bit more technical. So how do we design those ones too that connect with patients and providers as well? So yes, please let me know what didn't connect, because that would be very helpful. So
okay, I think we are coming close to the end here. We've got a bit of a closing coming up to do that. Certainly for the one about patient orientation, again, the research included patients, myself being one of them. I'm really particular about all of the jargon and all the rest of it. I understand what it is, but I have gone through it, and we certainly had that opportunity with the Cambian system to be able to put it in and to put in articles that were patient oriented and were not technical jargon loaded explanations about what was happening. So a lot of flexibility to implement that. I think that unfortunately ran out of time on our questions, but we've covered most of it, and I turn it over to Belinda there to finish the session. Over to you, Belinda.
So thank you
everyone.
for presenting, and just a little bit of information as we're closing up. So as I stated before, you guys can actually keep the conversation going via Twitter and our social media pages by using the Methods Matters hashtag. If you'd like to learn about this research group and the research that they're doing, along with other method cluster projects, you can also visit our website, and that is bcsupportunit.ca/methodclusters. So thank you guys again.
Thank you. Lots of
Thanks,
gratitude.
everyone. Thank you.
Bye.